Where are the others? Anyway, today's case is a 25, male patient. He complained of pain that is aggravated when his shoulder is flexed past 90 degrees. See your screens for pertinent points and physical exam results. I want you to study about shoulder and arms, and we will have a brief discussion.
I was late again, and all that reading got me really drained. I have an idea. How about we get together later and correlate the topic with a few cases?
I love that idea. That will bring in a little fun in learning. Come watch this good video that will help you understand the anatomy of the shoulders and arm.
The shoulder girdle, also known as the pectoral girdle, is formed by 3 sets of bones: the clavicle, the scapula, and the humerus. The clavicle, also referred to as the collarbone, is a roughly S-shaped bone. It is located between the sternum and the scapula and lies horizontally across the root of the neck. This is the first bone to begin ossification. This part is called the sternal extremity. This is the blunt, thick-ended proximal end of the clavicle and articulates with the clavicular notch of the sternum through a compound synovial joint containing an articular disc. Next, we have the acromial extremity, which is the flattened distal end of the clavicle. As shown below, it articulates with the acromion process of the scapula. The final region of the clavicle is the conoid tubercle. It is a small, roughened elevation on the inferior surface near the acromial end. It serves as the attachment area for the conoid ligament, a part of the coracoclavicular ligament. This is the subclavius muscle. It mainly stabilizes the clavicle during movements of the shoulder girdle. When it contracts, the first rib elevates and the clavicle depresses. This is the deltoid muscle. In relation to the collarbone, it allows you to flex your shoulder joint and rotate the shoulder inward. Next is the pectoralis major muscle. Its clavicular head flexes the humerus, while the sternocostal head adducts the humerus. Attached superiorly is the descending fibers of the trapezius muscle. Its upper fibers are attached to the clavicle to coordinate scapulohumeral rhythm, especially in elevating the shoulders. Lastly, the sternocleidomastoid muscle. It functions in head rotation and neck flexion. Moving on to the second bone, the scapula. It is a large, flat, triangular bone that lies on the posterior chest wall, between the second and seventh ribs, with 3 borders: superior, medial, and lateral. It has 3 large bony processes: the spine, the acromion, and the coracoid. This is the body or the costal surface and the neck of the scapula. The scapula has 4 muscles attached to it. Anteriorly, in its subscapular fossa, is the muscle subscapularis. It functions in the medial rotation of the arm. In the supraspinatus fossa is the supraspinatus muscle. Notice how it holds the head of the humerus in the glenoid fossa during abduction. In the infraspinous fossa is the muscle infraspinatus. It transversely abducts the arm at the glenohumeral joint and laterally rotates the arm along the transverse plane. The last muscle involved is the teres minor. It also laterally rotates the arm. Notice anything?
What could that be? They all rotate the arm. The 4 muscles must be what they call the rotator cuff.
The third bone of the shoulder girdle is the humerus. It is located in the arm and is considered the longest bone of the upper lip. It proximally articulates with the shallow glenoid cavity of the scapula, giving it its characteristic wide mobility. On the sides of the cavity is the glenoid labrum, which deepens it to increase its surface area. Now let's go to the parts of the humerus. This is the head of the humerus, the lesser tubercle and the greater tubercle. These tubercles serve as attachment for the rotator cuff muscles. If the blue region is the body of the humerus, then the purple region is the anatomical neck, and indicated below is the surgical neck. Between the greater and lesser tubercle is the bicipital groove. It is where the long tendon of the biceps brachii is lodged. These are the medial and lateral epicondyles, with the medial being more prominent. The following are the other important parts of the humerus. The capitulum and trochlea are articular surfaces for the radius and ulna, respectively, while the anterior fossas below receive the forearm bones during elbow flexion. Posteriorly, the olecranon fossa is found. It receives the olecranon process of the ulna during elbow extension. Observe how the olecranon process slides into the fossa during extension. The capitulum articulates with the depression on the head of the radius. The trochlea articulates with the trochlear notch of the ulna. During flexion, they occupy the anterior fossas of the humerus. The upper arm is divided into anterior and posterior compartments by the medial and lateral intermuscular septa. The anterior compartment of the arm is made up of the biceps brachii, brachioradialis, and coracobrachialis. They are all innervated by the musculocutaneous nerve, which pierces through the coracobrachialis muscle. It also originates from the C5, 6, and 7 nerve roots. The anterior compartment is supplied by the brachialis artery and anterior circumflex humeral artery, which winds around the surgical neck of the humerus. Now let's discuss the posterior compartment of the arm, the triceps brachii and the aconius muscle. They are both commonly used to extend the elbows. These muscles are innervated by the radial nerve, which originates from C6, 7, and 8. The triceps is supplied by a branch of the brachial artery, deep brachial artery, and the posterior circumflex humeral artery. Observe how it branches out from the main artery. Despite being in the same compartment as the triceps brachii, the aconius muscle is supplied by an artery which originates from the forearm blood supply. This is the recurrent interosseous artery. It ascends between the lateral epicondyle and olecranon.
So earlier today, a 24-year-old man named Zach Hilliard entered the emergency room, presenting with a scapula that appears to be sticking out on his right side, along with ipsilateral discomfort in his neck, shoulders, and back.
Isn't that a case of winged scapula? Any activities done by this man that could have possibly led him to acquiring this condition?
Well, he is currently employed in a grocery store, which entails moderate to high amounts of work using his arms, often overhead, to carry and stack boxes in high shelves. He also mentioned that he is currently pursuing swimming and cycling sports, which means he needs a very active lifestyle.
Basically, the scapula is held in its position by the tone and balance of the muscle attached to it.
Right. So what explains the winging of the scapula then?
The serratus anterior stabilizes the medial border of the scapula. Since the patient is used to making overhead arm actions, it is the most probable muscle affected. Without its proper function, the scapula sticks out like a wing.
And what nerve must be affected?
The long thoracic nerve.
But of course, damage of the dorsal scapular nerve and spinal accessory nerve can also result to a dropped shoulder, as they also innervate the rhomboid and trapezius respectively.
Does it require surgery?
Cases of scapular winging caused by damage to the serratus anterior nerve sometimes heal on their own within 2 years, but light physical therapy or other use of a brace for several months early in the patient's recovery may be recommended. Damage to the dorsal scapular nerve will most likely require a mix of physical and massage therapy. In the event that non-surgical treatment options aren't providing any relief, the doctor may recommend surgery.
I'd rather much reduce my risk of getting one by avoiding repetitive shoulder movements, avoiding too much weight on my shoulders,
and stretching your muscles.
Doctor, my neck and shoulder hurt and I can't seem to move my arm away from my body.
Good day, sir. I see you still feel pain. Don't worry. Your pain medication is on the way. The accident caused you a clavicle fracture, but we have operated on you immediately. The fracture keeps you from making wide arm movements, and that arm wrap is meant to keep you from moving it while your collarbone is healing.
A fracture? Am I gonna wear this thing forever? Am I not gonna be able to move my arms like before?
Oh no. Just keep your collarbone immobilized. And when it begins to mend, we can start with physical therapy, which includes mild movements, like grip strength, shoulder, pendulum exercises, just to ease the stiffness until you are able to perform more intense exercises. Then, your bone will recover. You'll get through it.
Small group discussions really make me nervous.
You will do great. You studied well last night.
Okay, class. Good morning. Now, let's start with someone who can enumerate and describe the joints of the shoulder girdle.
I would like to answer. These are the sternoclavicular joint, acromioclavicular joint, and glenohumeral joint. The sternoclavicular joint is where the clavicle articulates with the manubrium sterni and first costal cartilage. It is reinforced by the sternoclavicular ligament. The acromioclavicular joint occurs between the acromion of the scapula and the lateral end of the clavicle. It is surrounded by the acromioclavicular ligament and supported further by the coracoclavicular ligaments. Third is the glenohumeral joint, which occurs between the head of the humerus and the shallow glenoid cavity of the scapula. It has a transverse humeral and coracohumeral ligaments to strengthen its capsule and 3 weak bands of glenohumeral ligaments. Now let's watch these joints in motion.
Very well said. Since the glenohumeral joint is known for its great mobility, what stabilizes the humerus within the shallow cavity of the glenoid?
The glenohumeral ligaments
and the rotator cuff muscles.
Supraspinatus, infraspinatus, teres minor, and subscapularis.
Yes. Known for its mnemonic, sits. You are all correct. Now, describe the motion of the arm muscles.
The anterior compartment flexes the elbow joint while the posterior compartment works by extending it.
Good. Why is unscrewing a cork particularly advantageous to right-handed people?
Well, probably because corkscrews are generally made to unscrew in a clockwise direction to make use of the powerful supinator, the biceps brachii.
For left-handed people like me, supination of my left arm will only turn the corkscrew in the opposite direction. Nevertheless, the manufacture is based on the fact that supination is stronger than pronation, especially against resistance.
Right. Isn't it amazing? For my last question, what are the main blood supply flow of the shoulder to the arm? I hope you did not leave that out.
Oxygenated blood enters the shoulder area through the subclavian artery below the collarbone. As it passes through the armpit, it becomes the axillary artery, and as it continues along, it becomes the brachial artery, known to be the largest artery in the shoulder and arm. It then divides into the radial and ulnar arteries below the elbow.
The basilic and brachial vein drain into the axillary vein, while the axillary and the cephalic vein drain into the subclavian vein.
Well, I guess you did your assignment. Always read your anatomy book. That's it. Class dismissed.